So my name is Peter Sackey. I work as a physician at the Karolinska University Hospital in Stockholm, and I also do research at the Karolinska Institutet. And my talk is called Inhalation Sedation, Future Standard of Care. And my conflicts of interest are that I've worked as a medical advisor for Baxter Global and lectured for AbbVie, and I'm currently a medical advisor for Scandinavian Development Services, helping Sedana Medical with the AnaConDa trial. So, inhalation sedation in the ICU is a very long story. It's almost 30 years since the first patient was given isoflurane for sedation in the ICU. In the British Medical Journal in 1989, Kong and co-workers described the use of isoflurane, and in the conclusions, as you can see, they state, isoflurane is a promising alternative technique for sedation of ventilated patients in the intensive care unit. Now, what's happened since then? To start with, in the 80s and 90s, giving volatile anesthetics in the ICU was quite difficult. You had to bring in a vaporizer or an anesthesia machine, and also there were concerns about environment, and the anesthetic agents were quite expensive with open systems available then. And what happened in the late 90s was that a device was developed about 20 kilometers from where I live, as a matter of fact. It was called the AnaConDa. In those days, they called it an anesthetic conserving device. And this was meant to be used for anesthesia, but it turned out to be applicable also for ICU sedation. And I'm going to guide you through this device, for those of you who haven't seen it. The anesthetic conserving device is it's like a passive humidifier with a few extra features. So besides reflecting moisture and heat, it also reflects anesthetic agents. And there's a small infusion line that ends up with a porous rod, and you infuse isoflurane or sevoflurane to the anesthetic conserving device, the AnaConDa, and it's inhaled together with the gas air-oxygen mixture from the ventilator. And when the patient exhales, about somewhere around 80 to 90% is bound to adsorbed to an activated carbon filter in the device and reflected with the next inhalation. So what you need, besides a standard ventilator, is a syringe pump, which all modern ICUs have. You need the AnaConDa. It's good to have a gas monitor, and also scavenging is good to have as well. Since this device was introduced, there have been numerous studies describing the effects of inhaled sedation in the ICU. All these studies have been rather small, but they've all shown a pattern of effective sedation when you give about 0.5 to 0.8 Mach, short predictable wake-up times, mainly attributed to the rapid elimination through the airways. There's no need for any metabolism, and expected pharmacodynamic effects of inhaled sedation or inhaled anesthetics, the same you see as during anesthesia, but slightly less significant because the dose is lower. And there have been few reported side effects so far, in contrast to what we see with many of the other full-range sedatives. And what has been described as malignant hypothermia in one or two patients, and in the youngest children, reversible neurological symptoms with treatment ataxia. And as I said, short wake-up times that are very predictable are a feature of this treatment, and this means that patients, you can plan your extubation. So if you decide in the morning that you want to extubate a patient and they're on this treatment, within an hour you will extubate the patient, and if you don't, it's because something else is wrong, and that means that you can also trust your neurological evaluation of the patient very soon. And this is described, among others, in a study that I think Professor Storm will be talking about in a little while. There's some other postulated benefits of inhalational sedation, among others organ protection and improved long-term outcomes. This is a study by Stoyer and co-workers, and there's one more study also published from our group that indicates that troponin release after CABG is reduced when sevoflurane is given post-CABG. Is there any pulmonary protection? There are lots of animal studies indicating that, and this we'll hear more about as well in a little while when we'll have Professor Constantin talking about, I think you'll be mentioning your study. And so I won't say more about that right now. How about long-term outcomes? Could inhalation sedation impact long-term outcomes? Well, one of the things with sedation is that it's given for patient comfort. And what is patient comfort? That's one is how the patient appears to be right now. The second is the kind of memories a patient has after staying in the ICU. And there's a lot of studies describing traumatic memories from the ICU and the development of post-traumatic stress. In fact, there's many patients with post-traumatic stress after ICU stay as there are veterans from the Vietnam War or from the Iraqi War. And one of the reasons for this post-traumatic stress is the trauma when you get sick or when you're in an accident. But another reason is that you have frightful memories from the ICU. And specifically, delusions and hallucinations have been implicated when it comes to traumatic memories leading to post-traumatic stress. So there are a few studies that examine this, and we did one study, follow-up study, in our department that was published 2008. And there's also a study of sevoflurane sedation. And the interesting thing is that with both isoflurane and sevoflurane, it appears that the prevalence of traumatic memories with hallucinations or delusions are almost non-existent in these small studies. So this is quite interesting, I think, from a long-term outcome perspective, what kind of memories we leave the patient with after sedation. So how about mortality? Could that be impacted by this treatment? This is a study by Belgart and co-workers that was published last year in European Journal of Anesthesiology. And this study is retrospective, we should bear that in mind. But what these investigators found in their retrospective analysis was that patients that were receiving long-term sedation, more than 4 days of sedation with isoflurane, had a higher survival rate than patients sedated for more than 4 days, with intravenous drugs. And this is quite provocative, this finding, and it needs to be reproduced in a prospective study. Over the years, I started using this device in 2000, so that's quite many years ago, and I've had several concerns about it, and I know others have also voiced concerns, and you can read a lot about it. And these are 4 issues that I would like to mention. One of them is the Lua lock, second is working environment, dead space, and then finally the off-label status of this treatment today. When this was first marketed, this device, the syringes that came with it had a Lua lock connector, and that meant that it could be given intravenously, which was a risk. Now, this never happened, and what happened was that the manufacturer took notice of this, and they've added a glued connector with a unique thread. So now it's virtually impossible. You'd have to screw that off with force to give it intravenously. So that seems to be eliminated, that problem. Working environment. The people who work next to patients receiving inhaled anesthetics in the ICU often express concerns, and this needs to be taken seriously. We did a study in our department with isoflurane, and there's been a study on sevoflurane and isoflurane as well. And when everything is tight, when all the connectors are tight and you use evacuation, either active or passive scavenging, this is a passive scavenging, a picture of how you connect the outlet from the ventilator. When you use this scavenging and you keep everything tight, the levels of atmospheric pollution are very low. We had almost undetectable levels in our ICU with 4 air changes per hour. And in that study, we decided to disconnect the scavenging just to see what would happen. And we did that for, I think it was about 24 hours, and we didn't have levels above the recommended exposure limits. And these limits, I should say, are arbitrary limits that have been decided upon in an office, and they are way below the limits of what's considered toxic. So it appears that if you use the device in the right way, levels are far from the recommended levels, and those levels are far from what's considered toxic. So I would say it appears to be safe if it's used in the right way from a working environment perspective. There are certain procedures where you'll probably have higher levels, but even those procedures have been measured, for instance, bronchoscopy or when you extubate a patient, and you still stay under the recommended exposure limit, short exposure limit. Dead space. Until recently, the only available AnaConDa was a 100 ml AnaConDa, which has a dead space of 100 milliliters, as I just stated. And there's also a reflective effect that leads to a functional dead space that's slightly more than 100 milliliters. And this could pose a problem in patients with small tidal volumes and in children. And this has been discussed many times by different users and researchers as a problem. And it can become a real problem in, as I said, in children, for instance. And this has led to the development of a new device, a smaller device, 50 ml, which was, I think, released in February or March this year. And I anticipate that this is going to be the one that most people will want to use because it makes life easier, especially if you want to ventilate with small tidal volumes, as is recommended. So my fourth issue is the off-label issue. This drug is not approved for use for ICU sedation. It's been around for some 30, 40 years, I believe, isoflurane, and there's a lot of experience from anesthesia, but not for low concentration, long-term use. Today, about 1/3 of all drugs we use in the ICU are off-label, and if you look at pediatrics, it's even worse. This is a study where they looked at the drugs that children had when they left hospital after having a visit there, and almost 80% of the children had one or more drugs that were off-label. And if you go to an outpatient clinic, it's about 1/5 of all drugs that are prescribed off-label. And with that stated, off-label is not what we want to have, and this has been a discussion over many years. And so I'm happy to say that from June this year, there's a study that started, I'm going to tell you about in a moment. In Germany, the off-label use has been expanding. This is actually a picture from the company. The red dots, the small dots are small users, and the big red dots are big users. So there are very many places in Germany, at least, where this is used, isoflurane, for sedation. And there hasn't been a large study to assess the safety and efficacy. And now in June this year, a study started called the AnaConDa trial, and this is sponsored by Sedana Medical, and it's a randomized controlled phase 3 multi-center study. Presently, there are 11 centers recruiting and another 10 centers are planned to start. And the intention is to have a minimum of 300 patients, possibly up to 550, depending on an interim analysis. And the questions that we hope to have answered with this study is whether this is efficacious and if it's safe for patients. Patients will be medical and surgical, and with an anticipated need of invasive ventilation for more than 24 hours. And they'll be treated for up to 48 hours with either isoflurane or propofol with a target RASS of -1 to -4. And we anticipate that this study will be completed by the end of next year. So, back to the question, inhalation sedation in the ICU, future standard of care, well, remains to be seen, I'd say. It's the end of my talk.